Welcome to Weekly Neurology Deep Dive. This deep dive is for educational purposes only and provides a summary of a recent article titled A Practical Approach to Diagnosing Peripheral Neuropathies.
Please remember, this is just a highlight reel.
For the full picture, you'll want to check out the complete article. This deep dive has no commercial support.
We're focusing on a practical framework that neurologists can use every day to diagnose peripheral neuropathies, especially polyneuropathies.
Which a significant number of people.
Studies show that between 1% and 4% of the general population is affected.
And that number goes even higher.
This number increases to 13.2% for people over 80.
So that means a lot of our patients are affected by this.
Diagnosing polyneuropathy can be challenging with over 100 potential causes.
Where do we even begin?
The most common type of neuropathy is distal symmetric polyneuropathy.
For DSP.
Recognizing this and differentiating it from less common subtypes is key.
So we need to look for red flags.
We need to look for red flags that suggest something beyond a typical DSP presentation.
What are some examples of those red flags?
If symptoms are asymmetric, that's one red flag.
Makes sense.
Another is if the onset is sudden rather than gradual. Motor issues, particularly weakness being more prominent than sensory disturbances, can also be a red flag.
Okay.
Finally, intense sensory symptoms like ataxia or symptoms that don't follow a length-dependent pattern are atypical for DSP.
So if we see any of these red flags, further investigation with electrodiagnostic testing or EDX is needed to accurately diagnose the neuropathy subtype.
Exactly.
Let's talk about the initial patient encounter. What are the key points neurologists should focus on during history taking?
It's crucial to go beyond simply documenting symptoms.
Okay.
We need to understand the nature and timeline of those symptoms.
So the duration of the symptoms.
This helps pinpoint the location of nerve damage, the type of neuropathy, and potential causes.
What should we be asking about specifically?
Start by asking if the symptoms are positive, like tingling or burning, or negative, like numbness or loss of balance.
Interesting.
Some patients can experience both positive and negative symptoms,
Which can seem counterintuitive.
which can seem paradoxical, but is due to damage to different types of nerve fibers.
It sounds like understanding this distinction is crucial.
It is.
Okay.
Next, we need to differentiate between sensory and motor symptoms.
So are there problems with movement or strength?
While most neuropathies primarily affect sensation, we need to ask about muscle weakness, twitching, and difficulty with fine motor skills.
Got it.
Early motor involvement might suggest alternative diagnoses like motor neuron disease or polyradiculoneuropathies.
So asking the right questions about motor function is just as important as sensory testing.
Absolutely. Don't overlook autonomic dysfunction.
Oh, right. Autonomic dysfunction. The system that controls the automatic functions of the body.
Remember, these nerves control involuntary bodily functions,
Right.
and their involvement can manifest in many ways.
What types of ways?
Dizziness, irregular heartbeat, skin changes, sweating problems, bladder or bowel issues, and even sexual dysfunction.
Wow, that's a pretty wide range of symptoms.
Using questionnaires like the COMPASS can help formally assess autonomic function.
So you can give them a questionnaire about their autonomic symptoms?
Exactly.
That's a broad range of symptoms, making specific questions even more important. What else should we be considering?
The distribution and duration of symptoms are key.
Okay.
The symmetrical, length-dependent pattern, starting in the toes and feet, is a hallmark of DSP.
Makes sense.
But any deviation from this pattern could point to other causes.
Like what?
The duration is equally important.
So how long have they had the symptoms?
If symptoms develop within 12 weeks, considered acute or subacute onset, the possibilities narrow. This could suggest something like toxic exposure or immune-mediated conditions like Guillain-Barré syndrome.
So by understanding the specific pattern and timeline of the symptoms, we can start to hone in on the potential causes.
Right.
What about family history?
Family history is crucial, especially in younger patients.
Yeah, it can really point us in the right direction.
Inquire about ethnicity, consanguinity, related parents, and any family members with similar symptoms, foot deformities like high arches or claw-like hands, or muscle wasting in the lower legs.
What kind of information are we looking for in family history?
For example, a family history of carpal tunnel syndrome and autonomic problems could suggest hereditary amyloidosis. Early identification of this is key because, unlike many other neuropathies, there are now treatments that can slow the progression of hereditary amyloidosis.
So that's a great example of why a good family history can really make a difference.
It can.
That's a good example of why understanding family history is so crucial for diagnosis and management. Are there any other important factors to consider during history taking?
Social history and exposures are essential.
Okay.
Inquire about alcohol and illicit drug use, heavy metal exposure, especially occupational, and medications, including over-the-counter drugs and supplements.
So you want to know what they'd have been exposed to?
Some medications, such as certain chemotherapies and antibiotics, are known to cause neuropathy.
Mm-hmm.
And lastly, uncover coexisting conditions.
Okay.
Diabetes is the most common cause of DSP.
So their blood sugar control.
So blood glucose testing is crucial.
Okay.
Other important conditions to consider are infections like HIV, syphilis, or leprosy,
Right.
autoimmune disorders,
Mhm.
and dysproteinemias.
It seems like we need to take a truly holistic approach to history taking, considering everything from family history and lifestyle factors to potential exposures and coexisting medical conditions.
We do.
Now, let's move on to the physical exam.
Mhm.
What specific observations can provide diagnostic clues?
The physical exam provides tangible evidence to support our suspicions from the history.
Okay.
We need to go beyond the routine neurological exam and focus on specific observations.
Where should we start?
Begin with the general examination. Look for skeletal abnormalities like Charcot joint,
Also called rocker bottom foot?
a collapsed foot arch, high arches, hammer toes, claw-like hands, and muscle wasting, particularly in the hands and feet.
So you're really looking at their hands and feet very closely.
Palpate peripheral nerves for enlargement, which can be present in conditions like leprosy.
Okay.
Note any skin changes such as ulcers, hair loss, dryness, calluses, or unusual wear patterns on shoes.
It's interesting how even seemingly minor details can reveal so much about the underlying condition.
It can.
What about sensory testing? How can we go beyond the typical 10-gram monofilament test to assess different sensory nerve functions?
Using a 128 Hz tuning fork to test vibration sense is more sensitive than proprioception testing for detecting large fiber neuropathy,
Except in a couple of cases.
except in cases like vitamin B12 deficiency.
But we need to use different tools to assess different sensory modalities.
Mhm.
How do we perform these tests systematically?
For vibration testing, start distally and move proximally if vibration is absent,
Okay.
noting the duration of sensation, which should be at least 10 seconds. To test proprioception, move the patient's toes or fingers up and down,
So up or down?
asking them to identify the direction of movement.
Okay.
In severe cases, you might observe involuntary writhing movements of the fingers called pseudo-othetosis.
Oh, wow.
Small fiber testing is done with a pinprick,
Mm-hmm.
moving distally to proximally until normal sensation is felt.
So you're kind of mapping out the areas of abnormal sensation.
You are.
That's helpful. What about motor examination? How can we assess for subtle signs of motor involvement?
Most neuropathies primarily affect sensation, but strength testing is still crucial.
You want to make sure that they can move everything okay?
Weakness in the ankles and toes is often the first sign of motor involvement.
Makes sense.
Absent or diminished reflexes, especially at the ankles, are sensitive indicators of large fiber neuropathy.
So check those reflexes.
Yes.
Are there any specific muscle groups we should focus on during the motor exam?
The extensor hallucis longus, which extends the big toe, is often affected first because of its distance from the spinal cord. Testing this muscle can provide early clues about motor involvement.
That's a good point to remember. What about gait assessment? What are we looking for beyond simply observing the patient walk?
Have the patient rise from a seated position without using their arms.
Okay, so like a sit to stand.
This assesses proximal muscle strength even if they appear strong during direct testing. Observe their gait pattern.
And what are we looking for in the gait?
Patients with proprioceptive loss often have a wide-based, unsteady gait known as sensory ataxia.
Okay.
Those with weakness may have a high-stepping gait called steppage gait due to foot drop.
Mm-hmm.
Difficulty with tandem walking heel to toe can also be a sign, although it's not specific to neuropathy.
So we're looking for specific gait patterns that correlate with sensory or motor deficits.
Right.
Now that we have all this information from the history and physical exam, how do we determine the specific neuropathy subtype?
The red flags we discussed earlier are crucial for guiding our next steps.
So that brings us back to those red flags.
If any are present, electrodiagnostic testing is warranted to pinpoint the neuropathy subtype and refine the differential diagnosis.
This brings us to our next part of the deep dive.
It does.
We'll talk more about EDX and its role in diagnosing peripheral neuropathy,
Electrodiagnostic testing, or EDX, is like looking under the hood.
so we can see what's going on.
To see how the nerves are functioning, it helps us pinpoint the neuropathy subtype and refine our differential diagnosis.
Let's talk about those neuropathy subtypes. How does EDX help us distinguish between them?
EDX helps determine if the neuropathy is primarily affecting motor nerves,
The ones that control movement,
sensory nerves,
the ones that give us sensation.
or both.
Mm.
It also differentiates between axonal damage, where the long fibers of the nerves are damaged,
Okay.
and demyelination, where the protective myelin sheath is disrupted.
And the myelin sheath is that insulation around the nerves.
It is.
Understanding the type of damage seems crucial for pinpointing the cause. Can you give some specific examples?
A purely motor neuropathy
So only the motor nerves are affected.
could suggest multifocal motor neuropathy or certain hereditary neuropathies. A demyelinating pattern
So there's damage to the myelin.
points towards Guillain-Barré syndrome or chronic inflammatory demyelinating polyradicular neuropathy,
Also known as CIDP.
commonly called CIDP.
So the EDX findings can really help narrow down our list of potential diagnoses. Can you elaborate on what features we're looking for in the results?
In demyelinating neuropathies, EDX often shows slowed nerve conduction velocities
The signals are moving slower.
and prolonged distal latencies.
Okay,
Imagine the nerve signals hitting speed bumps, slowing down their transmission.
that's a helpful analogy. Are there other telltale signs we can see in demyelinating neuropathies?
In acquired demyelinating neuropathies like Guillain-Barré or CIDP, we might also see conduction block
So the signals are completely blocked.
or abnormal temporal dispersion, indicating patchy areas of demyelination. Conduction block is like a complete road closure on that highway the signal can't get through. Temporal dispersion is like rush hour traffic. The signals get slowed down and jumbled.
So both point to demyelination, but in different ways. How does this help us distinguish between different types of demyelinating neuropathies?
These findings differentiate acquired demyelinating neuropathies
Guillain-Barré.
from hereditary demyelinating neuropathies. Hereditary forms typically show uniform slowing without conduction block or dispersion.
So the pattern on EDX can help us differentiate between those two categories.
It can.
Moving on to the practical application of EDX. You mentioned earlier there's debate about its use in patients with chronic DSP, even without red flags. Can you explain that further?
The 2009 practice parameter from the American Academy of Neurology, the American Association of Neuromuscular and Electrodiagnostic Medicine, and the American Academy of Physical Medicine and Rehabilitation
That's not a mouthful.
recommended a limited initial workup for chronic DSP. This focuses on tests with the highest yield fasting glucose, serum protein electrophoresis with immunofixation, and vitamin B12 levels with methylmalonic acid and homocysteine.
If those initial tests are normal, and the patient have a classic DSP presentation without red flags, is EDX necessary?
That's where the debate lies.
Okay.
Some studies have shown that EDX rarely changes the diagnosis or management in such cases. For example, one study found that EDX led to changes in less than 1% of patients with chronic DSP.
Okay.
However, another study found that EDX changed the diagnosis or uncovered an additional diagnosis in 43% of patients and altered management in 41% of those with DSP.
So those are really conflicting results.
Yeah.
Those are conflicting findings. How do you reconcile these in your own practice?
The American Association of Neuromuscular and Electrodiagnostic Medicine provides helpful guidelines.
Okay.
They generally recommend EDX when the presentation is atypical.
It doesn't fit the classic picture.
Symptoms are moderate to severe, the diagnosis is unclear after initial testing, symptoms are progressing rapidly, or there's suspicion of a coexisting nerve disorder.
So there are specific situations where EDX is recommended, even in those DSP patients.
There are.
Moving on from EDX, let's talk about cerebrospinal fluid analysis, or CSF analysis. When is this indicated in the workup of peripheral neuropathy?
CSF analysis is particularly helpful when we suspect Guillain-Barré syndrome.
Okay.
We're looking for cytoimmunologic dissociation,
That's a big word.
where the protein level is elevated,
Mm-hmm.
but the white blood cell count is normal.
Okay.
CSF analysis is not routinely needed to diagnose CIDP if the clinical criteria are met.
Are there any caveats to interpreting CSF findings?
CSF protein levels can increase with age.
Okay.
But elevated protein alone shouldn't be the sole basis for a CIDP diagnosis, especially in patients with diabetes or those over 50. In unclear cases of CIDP, CSF analysis can provide supportive evidence and help rule out other conditions. For instance, findings of increased white blood cells could point towards infections like Lyme disease or HIV, or even neoplastic conditions like neurolymphomatosis or leptomeningeal carcinomatosis.
So CSF analysis can be useful in certain situations, but interpreting the findings in context is key.
It is.
What about peripheral nerve imaging? Where does that fit into our diagnostic workup?
Neuromuscular ultrasound and MRI can provide valuable anatomical information.
Okay.
Neuromuscular ultrasound is particularly useful for entrapment and traumatic neuropathies.
So you can see the nerves.
It allows direct visualization of the nerves, assessing for compression, swelling, or other structural abnormalities.
Okay, what about the role of MRI?
MRI is helpful in evaluating deeper structures like nerve plexuses and nerve roots.
Where the nerves come out of the spinal cord.
It's valuable for suspected radiculopathy, where the nerve roots are compressed as they exit the spinal cord. MRI can show the extent of the compression and identify any associated disc herniation or bony spurs.
Is imaging routinely recommended for all patients with suspected neuropathy?
The American Association of Neuromuscular and Electrodiagnostic Medicine advises against routine brain and spine MRI in patients with distal symmetric polyneuropathy.
So not for every patient.
In most DSP cases, the clinical presentation and neurological exam findings are sufficient to localize the problem to the peripheral nervous system.
So if it looks like DSP, we don't always need imaging.
Correct.
That makes sense.
Yeah.
It's about choosing the right tool for the job. Are there any new developments in peripheral nerve imaging that neurologists should be aware of?
There's a new classification system called the Neuropathy Score Reporting and Data System, or NSRAs.
Oh, that sounds interesting.
It standardizes the grading of peripheral nerve abnormalities on MRI.
Okay.
This categorization is based on severity of injury, presence of neoplasia or tumors, evidence of entrapment, signs of diffuse neuropathy, and any changes related to prior interventions.
So it's a standardized way to describe nerve damage on MRI. What are the implications of this new classification system?
NSRADS facilitates more consistent use and interpretation of MRI in peripheral neuropathies,
So it helps standardize the reporting.
potentially improving diagnosis and management.
That's an exciting development. What about skin biopsy? When is that helpful?
Skin biopsy is a valuable tool for diagnosing small fiber neuropathies. These affect the tiny, unmyelinated nerve fibers that control pain, temperature, and autonomic functions.
So those are different than the large fibers that we test with EDX.
Oh, yeah.
Since standard EDX only assesses large myelinated fibers, how do we assess small fiber function?
You're right, standard EDX can't directly assess small fibers. That's where skin biopsy comes in.
Okay.
It involves taking a small skin sample,
Usually from the leg.
typically from the leg,
Okay.
and examining it under a microscope to measure the density of small nerve fibers.
No, so you can actually see those small fibers under the microscope. That's good to know. Are there any specific considerations for skin biopsy that neurologists should keep in mind?
The pathologist needs experience in evaluating nerve fiber density in skin samples.
So not just any pathologist can read this.
It's also important to avoid potential technical artifacts that can affect the results, like crushing the specimen during the biopsy or allowing it to freeze during transport.
So proper technique and interpretation are crucial for accurate diagnosis. Now, let's talk about nerve biopsy. It was once a more common procedure, but it's less frequently needed now. Can you elaborate on why that is?
Advances in molecular diagnostics, peripheral nerve imaging, and skin biopsy have often replaced the need for nerve biopsy.
But there are still some situations where it's needed.
However, it still plays an important role in specific situations.
When might we still consider a nerve biopsy?
It's reserved for cases where the diagnosis remains unclear despite other investigations, especially for cryptogenic, acute, or subacute onset neuropathies that are asymmetric or multifocal.
So those more unusual cases. It sounds like it's a last resort when a definitive diagnosis is needed. Are there any conditions where nerve biopsy is particularly helpful?
Nerve biopsy can be valuable for diagnosing vasculitis, neurolymphomatosis, leprosy, amyloidosis, sarcoidosis, and nerve sheath tumors.
So while we have more options now, nerve biopsy still holds a place in the diagnostic workup for specific challenging cases. So we've covered a lot of ground in this deep dive into diagnosing peripheral neuropathies.
We have.
Let's recap the key takeaways for neurologists.
It all starts with a detailed history and physical exam.
Right, the foundation of everything.
This helps us identify those crucial red flags.
Those red flags are so important.
Asymmetry, acute onset, motor predominance, or non-length dependent symptoms.
Right, those are the things that are going to make us think, maybe this isn't a simple case.
Yeah, exactly.
That signal the need for further investigation.
Right.
If the presentation suggests chronic distal symmetric polyneuropathy, or DSP,
The most common type.
we can often make a diagnosis based on a limited initial workup. So what is that limited initial workup?
Those key initial tests are fasting glucose, serum protein electrophoresis, and vitamin B12 levels.
But if red flags are present, or if the diagnosis remains unclear after initial testing, electrodiagnostic testing, or EDX, helps pinpoint the neuropathy subtype.
It does.
And remind us again what EDX can tell us.
EDX can differentiate between axonal and demyelinating neuropathies,
Right.
identify conduction block or abnormal temporal dispersion,
Right.
and differentiate between acquired and hereditary demyelinating conditions.
So EDX really gives us a lot of information.
It does.
We also discussed cerebrospinal fluid analysis.
Also called a lumbar puncture.
It's essential for confirming suspected Guillain-Barré syndrome
Absolutely.
and can provide valuable information in other cases.
It can.
And peripheral nerve imaging can be helpful as well.
It can.
Neuromuscular ultrasound is particularly useful for entrapment in traumatic neuropathies, while MRI is valuable for evaluating deeper structures like nerve plexuses and nerve roots. And then we have this new fancy NSARDS classification system,
Yes, the neuropathy score reporting and data system.
which helps standardize MRI-based neuropathy assessment.
It does.
Skin biopsy is a valuable tool for diagnosing small fiber neuropathies.
Particularly if EDX is normal.
And while nerve biopsy is less frequently needed now, it remains an option for challenging cases where the diagnosis remains elusive despite other investigations.
It does.
It really sounds like diagnosing peripheral neuropathies is like putting together a puzzle.
It is.
You have to look at all the pieces,
You do.
consider all the clues, and use the right tools to get to the right answer.
A systematic approach, careful observation, and a willingness to embrace new knowledge are essential for effectively diagnosing and managing these complex conditions.
And there's always something new on the horizon.
There is.
What emerging diagnostic tools or biomarkers might further refine the evaluation of peripheral neuropathies in the future?
Research in genetic testing, proteomics, and metabolomics holds promise for identifying new biomarkers.
So really understanding those underlying mechanisms.
This could enable earlier and more accurate diagnosis and subtyping of neuropathies.
That's really exciting for the field.
It is.
Well, this deep dive has reinforced the importance of staying up to date on the latest advances in neuropathy diagnosis.
Absolutely.
I encourage everyone to read the full article for a comprehensive understanding.
A good one.
Thank you for joining us for this deep dive into peripheral neuropathies.